significant than that. Our lab values will be incorporated into each class, but if you have any questions, just let me know. And I also want you to remember that your lab values are all relative to the facility that you're working in. So just be mindful about that they may vary a little bit from what you find in one facility and what you find in your book, but that's just the way it is because they all have their own reference ranges set up specifically for them. So just kind of keep that in mind. So today we're going to do gallbladder disease and we're going to do Wilms tumor because neither one of those, I felt like after the test, you probably needed something that wasn't quite so cumbersome. And I feel like both of those are pretty straightforward and clear cut. Now on Wednesday, this is a lot of content too. So I encourage you to stay on top of things and try to keep up with your reading as we go along, because if you get behind on that, it's going to make it really hard to get caught up because we just have such a short time in this mini semester, as you know, with the other subjects that you've had, topics that you've had. On the 17th, we're going to do peptic ulcer disease, inflammatory bowel disease, and pyloric stenosis. On the 22nd, we're going to do the glomerulonephritis, prostate cancer, colon cancer, and we're going to start on kidney stones. And then on the 24th, we're going to do finish up with our kidney stones if we're not finished with them. We're going to do erectile dysfunction and BPH. And then I always like to do a review. And that's not giving you the answers to what's on the test, but it's just spending time and having you reflect on what we have spent the most time on and going over some of the key components that you need to be familiar with and you need to remember, okay? And I'll do that on the 24th. And then I think you have your test on what, the 27th? Yep, 26th.
26th?
Yeah, it's on a Friday.
Okay.
Yeah. So, and we'll be ready for it. Yes.
What PowerPoint are we starting with today? I didn't hear you when you said that.
We're gonna start with gallbladder, and I think I sent you all an email last week, or maybe the week before. No, it was last week, letting you know which one we were going to start with so that you could be somewhat prepared for it.
Are you going to post what you just said? What dates we're covering? What material?
I can.
You just went really fast, is all.
Okay. Well, I can go back over it if you want me to. Okay. We're going to do gallbladder disease and Wilms tumor today. Okay. And then on Wednesday, we're going to do peptic ulcer disease, inflammatory bowel disease, and pyloric stenosis. And that's in kids. So that content is very short. And so is Wilms tumor. So that's why I wanted to kind of try to get it in today as well, since we have limited time today. On the 22nd, we will do glomerulonephritis, colon cancer, and prostate cancer. And then we're going to start on kidney stones, but we probably won't get finished with all of that. And then on the 24th, we will move on to kidney stones and finish that content up. We will do erectile dysfunction and BPH. And then we will also do your review that day as well. Okay, and there'll be time for you, if you have questions, jot them down along the way, and we'll try to get them answered during that review time if possible. Okay, are we all set? All right, I'm going to try to share my screen with you. I hope it works for us.
You record as well?
Yes, I do. Let me make sure the record is on. Okay, can everybody see the gallbladder disease PowerPoint?
Yep.
Okay, all right, well, away we go. Gallbladder disease is something that is fairly common among the population. A lot of times people don't even know that they ever have it. They never have any signs or symptoms of it, and they find gallstones on an autopsy after they have passed away. I just wanted to review a little bit of the gallbladder anatomy for you. It's pear-shaped, and it can hold anywhere from 30 to 50 milliliters. That's the average capacity, but it can actually hold up to 300 cc's of bile before the patient starts getting into discomfort and having some issues with it. It's located along the inferior, which is the back surface of the liver. There's 4 anatomical parts to it. So if you're looking at a chart and you see that maybe they note a tumor on the fundus, then you're going to know where that is, because you know there's 4 major parts. The blood supply comes to the gallbladder through the cystic artery. The venous drainage occurs through the right portal vein. So if we have problems with our liver, we may have some venous congestion in that area, because the right portal vein is also associated with the liver. And then the lymphatic drainage goes into the cystic lymph nodes. What does the gallbladder do? Well, it serves to stores bile that is produced by the liver. And after we eat a meal, bile is excreted to help digest the food. Before we eat, if we could look at our gallbladder on an x-ray, it would be like that pear shape. It would be larger. And then once we eat and there's food in our stomach, it squeezes all this stored bile into the small intestines, and then it helps us to digest the fats. So that's why we have a problem with eating high-fat diets if we have gallbladder disease. Okay, so let's talk a little bit about some of the diagnostic tests that we can do before we get into the patho. Some of the most common tests that you're going to see used is an abdominal x-ray. That's going to help us see what the gallbladder looks like, if it has stones in it. Sometimes you can see those with a regular abdominal x-ray, and sometimes you can't. It just depends on how big they are and where they are and what they're made of. We could do an oral cholecystogram, which is where a liquid is swallowed and it follows through the GI tract, and as it goes through the gallbladder, they're able to actually visualize it. Ultrasound would help us see the gallbladder as well as surrounding structures. We could see other structures around the gallbladder that might be causing a problem as well. CT scans would be helpful. HIDA scan is probably one of your most common scans that you're going to see, and it actually shows us how well the gallbladder is actually functioning. So it lets us, or gives us the ability to be able to see that bile and it being excreted from the gallbladder. Is it being excreted? Is there sludge in the gallbladder? What's going on there? So that's a very helpful test that you will see ordered quite often with patients. MRIs may also be helpful, and they also help you look at surrounding organs and tissues. And then an endoscopic retrograde cholangiogram. Typically, the cholangiograms are used more to diagnose a certain condition. Let's say that somebody has a gallbladder removed, and for some reason a stone gets left behind in the duct. then this would be helpful in identifying that as a problem. And then the ERCP is a procedure that is used in conjunction with not only diagnosing the problem, but fixing the problem as well. So let's talk a little bit about who is the most likely to have gallbladder disease. Well, like I said before, it's one of the most common problems affecting the digestive tract. Age, as people get older, they have more likelihood of developing gallbladder disease. Usually females who are aging, who are obese, pregnant, or eat a lot of fatty meals, especially in the years of 20 to 60 years old, is twice as likely to develop gallbladder disease, and it is more common in women. Ethnic background is also a common factor. It seems that African Americans tend to be a little bit more likely to develop gallbladder disease. We've already talked about the obesity and pregnancy and dietary factors. Other conditions that may contribute to it include Crohn's disease, terminal ileal resections, and gastric surgeries. And when you think about those diseases, what kind of problems do they present? They all present malabsorption problems, don't they? That's one of the problems that goes along with all three of those particular diseases. So it's not uncommon to have those problems along with the disease. There's a couple of other diseases that I wanted to make sure that I mentioned to you. Spherocytosis is a hereditary condition, and it's basically what happens is that, you know, our blood cells are disc-shaped. In this particular condition, they become sphere-shaped. So with that being the case, they are less flexible. They have less surface tension than our normal healthy blood cells do. So what do you think that does to their oxygen carrying capacity?
It decreases it?
It does. And
is
what
it like
about
sickle cell? I'm sorry.
It is. And sickle cell is one of, the next one. And it's caused by a sickling of the cells. And the cells kind of form into like a little half moon, and then they get stuck in the vessels, causing the pain and swelling and all kinds of circulatory problems that cause a lot of pain for these patients.
Correct.
And you also will see a decrease in the carbon dioxide exchange, because if you don't have that surface tension and you don't have the oxygen being carried as it should be, and anemia goes along with this. So you don't have the blood cells there to carry all of the oxygen and the nutrients that is needed. Thalassemia is another hereditary disease. Basically, with this particular condition, there's less hemoglobin, and it's all related to fewer red blood cells. So if we have fewer red blood cells, what are some of the problems that we're going to see? What's going to happen to our oxygen?
It's going to decrease.
Decrease.
It's going to be low because we don't have enough red blood cells to carry the oxygen that we need to these other vital organs. And there's basically 3 types of thalassemia, but I'm not worried about you knowing those. I just wanted to put it out there for you so that you would be aware that it's a hereditary problem. So out of this list, what would be considered modifiable?
The
obesity.
dietary
Okay.
factors.
Okay. All right. Yep. Obesity and the dietary factors. Maybe pregnancy.
Maybe
it just
pregnancy.
depends.
Yeah.
It just depends. Yeah.
I have a question. I just want to be sure. I didn't mean to send it to you in the chat.
Oh, that's okay.
The dietary factors, greasy foods, correct?
Uh-huh. Yep. those that are high in fat, because when you think about how dense they are, they're very hard to digest, because when we eat a heavy meal, maybe that's full of macaroni and cheese and potatoes and fried chicken and bread, think about how heavy that is and how hard that is to digest. So that's why we have problems with it. Some of the conditions that result from the gallbladder disease include diabetes type 2, insulin-resistant diabetes, and then, of course, we've already talked about females being more likely than males to develop gallbladder disease. First-degree relatives of patients with gallstones have a twofold greater prevalence of developing them. And like I said, you know, some we never even know that they have them until they do an autopsy on them. But they do develop in about 3 to 5% of the 3 to 5% of the patients become symptomatic each year when they're have a problem with gallbladder disease. Now, there are two kinds of gallbladder disease that I did want to point out to you. One of them is called acute, and this is probably the most common one that you're going to see, and it's also called calculus. So you may see it termed either way. And basically what happens with this one is that there is a chemical irritation, or either there's stones that cause an obstruction, which leads to cholelithiasis, which is an inflammation in the gallbladder. Now, one problems that can occur with our gallbladder if they have gallbladder disease and it's not treated promptly, they can suffer perforation of the gallbladder due to gangrene, because the gallbladder just gets larger and larger and more swollen, more inflamed, and then it ruptures, and then you have a belly full of bile. So that can be a problem. What is an end result of something like that happen? What is a given with having contents like that in the abdomen?
Infection.
Peritonitis. Yeah, they're most likely going to have peritonitis. Now, how would you, what are some signs and symptoms you would look for with peritonitis?
Maybe nausea and vomiting.
Okay. What about abdominal distension? Because they've got an infection in there. So they're going to have tenderness. They may have abdominal distension. They may have nausea, vomiting. And if it progresses, they can become septic from it and they can die. So that's something that we really need to try to keep in mind whenever we're trying to take care of these patients. And we'll talk a little bit more about signs and symptoms in a couple of minutes. Basically, the stones form from settling of solids, because, you know, I told you about that sludge in there when it just kind of sits there and then it solidifies. And most of the gallstones are composed of either bilirubin salts, phospholipids, and cholesterol. It's usually a combination. And the way that they're classified is through their cholesterol content. 80% of the stones that we see are cholesterol stones, which means that's the majority of what they have. 15 to 20% are called black pigment stones. We don't see that much. And then there's a small percentage of brown pigment stones. Now, we don't know what these stones are until they're taken out and can be analyzed. So you can't really look on an x-ray and say, oh, that's a cholesterol stone or that's a brown pigment stone, because they have to take them out and then analyze them in the lab to get a definitive picture of what kind they actually are. Let's talk a little bit. We talked a little bit earlier about the acute cholecystitis, and this is just where a stone obstructs the common duct and the bile gets trapped in there. So then that can lead to infection and gangrene. We really don't know what the exact method of formation of the stone is. We just know that it's caused by the delayed emptying of the bile, and it causes the biliary stasis within the gallbladder. And then when you have stones in there, the infection can also set up around those stones as well. The second kind that I want to talk to you about is called chronic cholecystitis. Typically, you're going to see that one. It's called acalculus too. So if you see it referred to as acalculus, it's the same thing. Typically, it's an inflammation, but these patients usually don't have any stones. The emptying, of course, is impaired, just like it is with the acute. But for some reason, there is a decrease in the flow of the bile. Maybe it's an anatomical structure, or maybe there's a reflux of the pancreatic enzyme into the gallbladder that may be causing the inflammation. We're just not real sure about that. But these patients run a higher risk of developing cancer, or the chronic ones run a higher risk. The chronic ones usually run a higher risk of developing cancer than the acute ones do. And these symptoms usually develop over time. Now, the acute, it comes on very suddenly most of the time, and they're just totally miserable, just writhing in pain. And with the chronic cholecystitis, in between the episodes, they usually are fine. They don't have any problems at all. So let's talk a little bit about the signs and symptoms with the chronic. Like I said, they're going to have recurrent attacks. The pain can be located in the epigastrium or the upper right quadrant, and it may radiate through to their back. It's very severe and sudden, and they're usually well in between episodes. Now, the one thing you want to make absolutely sure about when you're dealing with these patients is that you've ruled out any cardiac problems, because the pain can be very similar and in the same location as cardiac pain. So what are some things that we might want to do to try to rule out cardiac problems?
Troponin and EKG.
Okay, troponin, EKG. And if you were assessing their pain, what would you assess for? How would you assess it? What kind of questions would you ask them?
EQRST. Like, where's the pain? Is it precipitating anywhere?
Okay. Yep. Does it go anywhere? How long have you had it? Does it seem to be related to food intake? Now let's talk a little bit about your lab values. Your WBC, it may be elevated. If it's acute, it's more likely to be elevated than it is if it's chronic. It may be normal with chronic. Our liver function test, we're primarily looking at the AST, that may be elevated, and the LDH. What's your normal AST? Google it. What's your normal AST?
10 to 34.
Okay. All right. And if you have liver involvement, that's when you're going to see these enzymes elevated. What is your normal LDH?
Is it 140 to 280?
It could be, yeah. It depends on your lab, your reference range.
Okay.
So yeah. Now, two other enzymes that we might be concerned about too is your amylase and lipase. Which organ are they associated with?
The pancreas.
Yes, the pancreas, right. So the amylase is anywhere from 30 to 220, and your lipase is usually 0 to 160. And you're going to see those elevated if you have any type of liver or pancreas involvement. Now, we also may see an elevated direct bilirubin or the conjugated bilirubin, and our normal for that is 0.1 to 0.3. And whenever we have, the liver is our main source of forming bilirubin. So when we have an obstruction there, that's when we're going to see abnormalities in that lab value as well. Total bilirubin is also another lab value that we may look at. 0.3 to 1.0 is typically your normals. And these are going to be elevated with any type of an obstruction or any type of damage to the biliary system. What about, how do you think the patient is going to present if we have an elevated bilirubin?
Jaundice.
Jaundice?
They may be jaundice, yes. And one thing to remember too, I had a patient many, many years ago, and she was in a motor vehicle accident, and her common bile duct was lacerated in the accident, and it was not picked up on right away. So she just kept getting sicker and sicker and sicker. And finally, whenever they realized that that's what the problem was, we transferred her to another facility, but she still passed away. So, but she had all of the, when I look back on it now, she had all of those signs and symptoms. She became very septic because of it. So those things can definitely happen. We've already talked a little bit about the acute cholecystitis.
Julie, I have a quick question before you move on.
Yes, ma'am.
For the chronic cholecystitis, did you say that it's usually not because of stones?
Correct.
Okay.
It's usually caused by some type of an obstruction. And because the gallbladder becomes very thick and fibrous and it doesn't work well, that's what increases these patients' chances of developing cancer, whereas you don't have that problem with the acute phase.
Okay, I was just making sure I heard you right. Thank you.
Okay, you're welcome. No problem.
And can you repeat the levels for the AST and the LDH?
The AST is usually going to be anywhere from 0 to 35, 10 to 35. What we would be concerned about is if it was up to 90, 100, then we would start looking at, well, what's causing that? What's our other problems going on here? And then the LDH is usually anywhere from 100 to 190 if there's liver involvement. So patients with acute cholecystitis are usually, like I said, they're going to present with nausea, vomiting. They may have diarrhea, a lot of gas, dyspepsia. They may complain of pain in the right upper quadrant, like I said before, which may radiate through to their back. And these symptoms do not usually go away. They are constant. Okay. And we've already talked a little bit about the lab tests too. They may have an elevated white count. What's your normal white count?
4,000 to 11,000?
To around 10. Okay. Depending on your lab. And just remember that too. But there again, like I told you before, your white count may be perfectly normal. It may not be elevated at all. If you have a very high white count, that's when you really want to get concerned about any types of perforations or if there's any type of gangrene infection in there. And we've already talked about some of those particular lab tests. Now, some of the things that we want to look at for differential diagnoses is, do they have a peptic ulcer with or without perforation? Do they have a history of any type of peptic ulcer disease? Pancreatitis. Have they had a problem with pancreatitis in the past? Or do they consume alcohol? Or have they been on some medication that may have caused them to develop pancreatitis? Appendicitis, hepatitis are also things that we want to rule out. And of course, myocardial ischemia, we've already talked a little bit about that. Pneumonia, why would you be concerned about pneumonia?
If they're in pain, they might not be breathing very deeply.
Okay, right. And if they do have pneumonia and it's causing them to have pain, every time they breathe, that diaphragm area moves, doesn't it? And that's where the gallbladder and the liver and the pancreas are. So it causes them to be uncomfortable. Pleuritis may also be a problem. And then, of course, if they've had any type of a herpes infection or virus along the course of the intercostal nerve, because where does that nerve located? It's located right there in that same area coming around your side, isn't it? So that may be a problem for them as well. So we have to rule out all of these things to make sure that we're not missing anything. And they could have gallbladder disease as well as one of these other problems as well. So that's why we really have to do a lot of questioning on our assessments and, you know, try to get down to when it all started and what makes it worse, what makes it better. So how are we going to treat these patients? Well, they're going to need IV fluids. What kind of IV fluids would you want to use for these patients? Any idea?
Would it be LR?
Could be, or normal saline. Because at this point, if our labs are all, our electrolytes are all normal, then we really don't need to change anything, do we? So we want to choose an isotonic solution. We're going to choose antibiotics, something that is fairly broad spectrum, that is going to cover any type of bacteria that may be caused by this inflammation in the gallbladder. They're going to need pain medication. How are you going to assess your patient to determine if they need more pain medication? What are some things you're going to look at?
Rating their pain on a scale.
Correct.
Okay.
Their
What
vitals.
else? Their vital signs. If their respirations are 8 and they're telling you that they're hurting, are you going to give them 2 more of morphine?
No.
Probably not, because if you suppress the respirations, then we have a bigger problem than them being uncomfortable. Laparoscopic cholecystectomy, that is probably the most common procedure that is used currently. It helps with this particular procedure, the patients can recover much more quickly. They are less likely to have complications, and they are able to go home much sooner. Some of them go home the same day if they don't have any problems. And then if it's a situation to where it can't be removed laparoscopically, then they may have to have an open cholecystectomy. And usually the incision is just maybe about 3 inches long. It's not very long, but it is considered a major surgery. So how would we care for those patients post-operatively?
Check the incision,
Okay.
Antibiotics.
treat their pain.
Okay. What else?
Watch for infection.
Okay.
Off
And
diet.
go ahead.
Off diet.
Well, we want to get them up and moving too, don't we? We want them to be coughing and deep breathing and using that incentive spirometer and achieving as much as they can achieve. And we've talked about this in some of my virtual clinical groups, is that not everybody's going to be able to achieve 1,500 to 2,000. But the point is, with the incentive spirometer, that we are moving forward and we are making some progress with it. All right, let's talk a little bit about some of the nursing concerns that we may have with these patients. We've already talked a little bit about some of them as far as the pain management and infection. What about nutrition?
Decrease fats.
Okay. All right. And if you're given a choice between baked fish and fried chicken, which are you going to choose?
Baked fish.
Yes. Yes. Anything that has less fat in it is what we're aiming for, because it's much easier to digest. And we've already talked a little bit about the post-op complications. We don't want them to develop any type of superimposed lung infections. We don't want them to develop any type of edema, DVTs. We want to make sure that they're up and they're moving and they don't have a chance to form clots. What would be our management to prevent them from forming clots post-operatively?
Get them out of bed. You could give them heparin, Levinox.
STDs.
Okay,
Use Ted hose.
okay, all right, good job. Now, what about some psychosocial concerns that we may have with these patients?
Anxiety.
Well, they're hurting, aren't they?
Body dysmorphia.
Yes, it may be a problem. They may have a problem with their body image. They may have a problem with role reversal. If they have acute cholecystitis and they have recently gotten sick and they've had to be hospitalized and they're not able to work and they were the primary breadwinner, that might be a major concern too. So those are all things that we have to look at whenever we're assessing these patients. And some of the most common things that cause patients to have cholecystitis results from them becoming septic from some other type of an infection, a severe trauma, or a burn, long-term use of TPN, because what does it have in it? It has a lot of fat in it, doesn't it, when you use the lipids daily. Multi-system organ failure is also common with these patients, especially if they are not treated early on. Any type of major surgery also predisposes them to developing the cystitis or cholecystitis. Sorry about that. But any questions about any of that?
I actually have one.
Sure.
So just to recap, the big ones is the acute cholecystitis, which is because of a blockage from a stone. And then chronic cholecystitis is because there's a blockage from like some kind of like abnormality. Okay. Just want to be sure.
Yeah. And when you think about it, think about the stone. Well, what's happening is it's automatically occluding that duct. So that would stand to reason that it would be an acute episode, wouldn't it? So, okay. All right. Okay. Any other questions that you can think of? Don't have any other questions for me on that? Okay. Now, I do want to talk just a little bit about some of the complications that can occur with these patients. They can have necrosis, like we said before, with the gangrene or the perforation of the gallbladder. They can have it's a condition that's called empyema, and it's where there's a collection of like pus, a collection of infection between the two layers of the tissue that line the lungs as a result of this particular condition. Fistulas can occur, and that's the opening between two body cavities. And then we've already talked a little bit about the liver and the pancreatic involvement too. So that's really all we're going to talk about on this today. We just kind of kept it fairly simple and to the point. Do y'all need a quick break?
When you say liver and pancreatic stuff, can you just reiterate that? Because you went a little fast for me.
Okay. Remember your lab values. That's what you're going to be looking at. Whenever you're looking at liver involvement, you're going to be looking at your AST or your LDH. and that can it can result from inflammation related to the liver, or if they develop a superimposed infection or gangrene that has set up in there because their gallbladder ruptured and the infection has spread to their pancreas, liver, that can be a problem. And the same thing with their pancreas. You may see problems if there has been gangrene or some type of a rupture in there that has spread to the pancreas. Does that make sense?
Yeah, thank you.
You're welcome. Okay, do you need a quick break?
I'm good if everybody else is. I don't know about everybody else.
I'm good.
Okay.
I'm good.
I'm going to move on to Wilms tumor, and it's a very short one. It won't take us long at all to get through that one. Well, it's moving a bit slow today. Okay, are y'all able to see that at all? To see my Wilms tumor?
We don't see anything on the screen.
Okay.
I was unable to pull up the PowerPoints today.
Okay, did anybody else have a problem?
I didn't have a problem, but some of them were kind of slow just because of the audio content.
Yeah. Okay. Let me see. Okay, let's see if it comes up now. Okay, are you able to see it now?
Yeah, we can see it now.
Okay, let's see if I could take some of this stuff off of it. Okay, so I'm not going to read the objectives to you. You can read those. They're self-explanatory. This is a tumor that is occasionally seen in children. It's not that common. It's like, I think, 8 in a million. So, but it is something that I wanted to mention to you because I wanted to make sure that you were familiar with it in case you should see it again on NCLEX. Because it is one of the most common rare forms of kidney cancer in children. Is a nephroblastoma, nephro meaning kidney. And basically what happens is this starts developing in the embryonic stage of the child developing, and there's an error in the DNA. You remember the cell cycle and all those, the DNA, the RNA, the resting phase, the go phase, the pool stage, and all of those stages. Well, all of those stages, everything has to work together in harmony. And there's so many places that there are things that can go wrong. And that's what happens here. There's an error in the DNA makeup for some reason. and it can be in one or both kidneys. It's the second most common abdominal tumor in children, and it is 1 in 8 in a million. You typically don't see it over the age of 5. Typically, it is seen between the ages of 3 and 4. That's the most common. But once they get to 5 years old, it's less likely that you're going to see it. So what are some of the symptoms of this tumor? Well, they're going to have fever. They may have some shortness of breath because, these little kids, they're little. So they don't have a lot of intra-abdominal space. So when you have a tumor that's growing in there, that's putting pressure up on their diaphragm and their rib cage, isn't it? Because it's sitting on their kidneys, which is just like right there at their diaphragm, because they're so short. Their little bodies are so short. And of course, anything that involves the kidneys, there's a good chance that they're going to have nausea and vomiting, and they're not going to feel like eating. They may complain of some constipation, and you may actually be able to even feel the mass. If the child is very slender, you may actually be able to palpate the mass on their abdomen or through their abdomen if you're doing an assessment on them. Of course, with the kidneys being involved, hypertension is almost always a given as well with these particular kids. And then that's also going to have to be treated with your ACE inhibitors or your beta blockers. Sometimes they have a combination of several drugs on board to try to control their hypertension. And then hematuria. Why do you think they might have hematuria?
Just because there can be some irritation in the kidneys. So whenever they void, it could be bloody from the irritation.
Right. And when you think about the kidney, and then it's got this metastatic tumor or this malignant tumor sitting on it, then what is that doing to the glomerular filtration in the kidney? It's not able to function as it should. So that may be when we see the hematuria, and we may see other toxins as well that are like protein spilled in the urine. I wanted to go over the staging of the tumors in these kids, just so you're familiar with it. It's not something that I'm going to ask you on the test, because I don't feel like this is something that you need to know in order to take care of the patient. But I think it's something that you just need to be familiar with, so that if you have a child that has this, you know what goes along with that particular stage. With stage 1 is found only in one kidney, and it can be contained and removed, so it may be encapsulated, and that means it hasn't spread anywhere. Stage 2 has spread, but it can be successfully removed. Stage 3 has spread to the lymph nodes, so we have a lot more issues going on there, and it can spill into the abdomen even before or during the surgery, and they may not be able to completely remove it. Stage 4 has spread to other major organs such as the brain, the liver, the bones. And then stage 5 is when the cancer has been found in both kidneys. So what are some diagnostic testing that we can do with these? We can do ultrasound, because that's going to let us look at the tissues surrounding the kidneys as well as the kidneys themselves. They may order a CAT scan. They may order a PET scan, because we really want to know if this cancer has metastasized elsewhere, because that will certainly make a difference in the way we proceed with treatment. Because if they already have bone metastasis and brain metastasis, chances are that the radiation and the chemotherapy are not going to be effective, and they might not even be a surgical candidate at that point. And then, of course, our lab tests, we're going to look at our RBCs, because we're spilling blood in the urine, so our RBCs may be lower with our hemoglobin, and then our white count may be elevated if they are having problems with inflammation and infection. And I wanted to include this treatment plan that is from the International Society of the Pediatric Oncology Association. Stage 1, which you remember was it was encapsulated. They were able to go in and remove it. Typically, they'll do chemotherapy for about 4 weeks, and then they'll go in and resect the tumor and then give them more chemo for about 4 weeks. And all this is relative. It depends on the patient and their condition and how well they tolerate the chemo. Stage 2, they're going to do the chemo preoperatively. Why do you think the chemo preoperatively would be beneficial?
Does it decrease the size of the tumors?
Yes, it could. It can decrease the size, and it can also decrease the number of living tumor cells. Now, unfortunately, as you know, chemotherapy damages good cells as well as the bad ones. And then usually they'll be given a triple chemotherapy for about 27 weeks. So it's a pretty long haul for them. And then stage 3 is when they start adding the radiation to their therapy as well. And then stage 4 is very complicated. We get into the triple chemotherapy before surgery and then after surgery for 9 weeks. And these remission may or may not occur even after all of these interventions. So it can be up to 34 weeks or more, and they can also add radiation to it as well. And what do you think some of the main things that we would think about with these patients are? What about education with the parents? That's going to be so important. So much of what you do every day is going to be associated with education, whether it be the parents, the patient, the family members, but we want to teach these parents, signs and symptoms, discharge planning. What do you want to teach them to look for whenever they're taking this child home? If they start having any swelling, if they start having any leaking from their op site, decreased urine output, a fever, anything that would be indicative of a complication, they need to know that they should notify their primary care physician so that they can intervene as soon as possible and the child doesn't have any long-lasting effects from it. And depending on the stage, it depends on the prognosis. If it's stage 3 and 4, it's iffy as to whether they're going to do very well or not. Stage 5, they do not do well at all. Stage 1 and 2, they do have a more positive outcome with having a tumor in those particular stages. So, and that's really about all. I just wanted to touch on it briefly with you so that you would be somewhat familiar with it. Do y'all have any questions?
I do. So as far as you said, we didn't need to know the staging of it for testing purposes. So as far as treatment goes, we just need to know they treat it with chemo, radiation, and they can remove it.
Right. And the length of therapy depends on the child, and it depends on the physician. So, and these are just ballpark figures of what I gave you, is just kind of a norm, but it all depends on so many extenuating circumstances. But
okay, thank you.
Okay. Any other questions? Okay. Well, I guess I will see you Wednesday. I'll send you out an invite, and we'll do peptic ulcer disease, inflammatory bowel disease, and pyloric stenosis on Wednesday.
All right. Thank you.
All right. You're welcome. Y'all have a great afternoon.
You too.
Thank you.